Hi, we're going to talk today about biliary ultrasound. So, a brief introduction to sort of what we're doing and why we're doing it. As far as patients who present with abdominal pain, one of the more common diagnoses we think about, especially with patients with right upper quadrant pain, is whether or not they may have gallstones or a gallbladder infection. So, we're going to very briefly discuss a little bit of anatomy. We're going to walk through how you do the ultrasounds and when they become useful. So, let's start by looking at the anatomy. So, if you're looking up in the right upper quadrant, you'll have the liver up at the top right under the diaphragm. You'll have a gallbladder right next to it, which will hold a lot of the secretions from the liver for your digestive enzymes that will get released through the cystic duct and the common hepatic duct into the common bile duct, and that common bile duct will go into the small intestine. So if there is potentially cholelithiasis, when the gallbladder contracts, and cholelithiasis being gallbladder stones, when the gallbladder contracts as you're eating, patients can get very severe right upper quadrant pain. And often that pain can be debilitating enough, so much so that you need to take out the gallbladder for patients to function. Some of which can be controlled by lifestyle modification, but that's harder to do for patients often. The other thing to talk about is that if you get an infection of the gallbladder, usually caused by a stone that causes an obstruction, and for the digestive enzymes to build up behind it, you can get something called cholecystitis. Now, you can also get what's called acalculous cholecystitis, as in cholecystitis without a gallstone. It's less common, but it's another thing to think about, especially in critically ill patients. And then as you're going through this entire approach, really your approach is going to be to look at the ultrasound, to look at the gallbladder in a couple of different axes and answer those clinical questions. So, first and foremost, we're going to discuss that when you're putting the ultrasound probe on, you have two approaches. You come up lateral, here in this right upper quadrant view, and you'll look in from almost this window. So you'll be peeking in from here and getting a view of the gallbladder from this side. Or you can look anteriorly and put the probe on the front of the abdomen, and basically your probe will lie right over the gallbladder, and you could look at it in short and long axis. We'll talk through what those are one more time momentarily. So you have a couple of clinical questions. Clinical questions are, is cholelithiasis present? Is cholecystitis present? And within cholelithiasis, you're simply looking for gallstones. For cholecystitis, there's a few different markers that can be helpful. Is there gallbladder wall thickening? Is there pericholocystic fluid? And is there a sonographic Murphy's sign? We'll talk about each of those momentarily. But basically, as a reminder, any point of care ultrasound study should be binary. Yes, no questions as much as possible, with little room for subtlety. Because the rationale there being that if you have any confusion or if you have any concerns, a definitive diagnostic test is helpful. But if you're seeing this patient in the outpatient office with severe right upper quadrant pain and you're going to try to get them scheduled for an ultrasound, which might happen next week, diagnosing them with cholelithiasis or potentially saying, hey, I'm worried about cholecystitis early, is a good thing to do. So let's talk about how you're going to have the probe placed. So if you're looking out lateral, the probe is going to be out here on the right-hand side, with the probe marker pointed towards the patient's head. And this is the first view you're going to take, and you're going to sweep through. As a reminder, probe marker always goes up to the head or patient right, except in cardiac, as you've already seen. If you are ever confused about where that probe goes, just think through those two basic rules and you'll be fine. Now, if you were looking from an anterior perspective, you'd put the probe here, right underneath the ribs, and you'd basically be fanning up and down to get the entire sweep of the gallbladder in long and short axis. So let's talk through long and short axis again, because it is a concept that often makes people a little uncomfortable. So we're going to use a vein as an example because that's easiest. So if this is your vessel running across the screen here, the ultrasound beam would cut across it in the short axis of the vessel. So what that means is you wouldn't see the length of the vessel stretched out, you would see a cross-section, a symmetrical looking cross-section. Generally speaking, short axis is almost always going to be symmetrical compared to long axis. And now if you rotated the probe so that it runs parallel to the vessel instead of perpendicular to the vessel, your beam would go parallel, and you would also see a cross-section in the long axis, where there would not be as much symmetry. We'll see what that looks like in a second. So this is what short and long axis look like on a person with a vein. So there you can see vein there, and you can see it's in short axis, and they're tracking it, and it stays symmetrical the whole way. This, on the other hand, is a long axis vein, and there you can actually see a needle in the vein. Okay, so let's talk through a couple of cases. A woman presents with severe abdominal pain, and you're worried that she has cholelithiasis or cholecystitis. So, You start by putting the probe in the right upper quadrant, and this is a lateral view. You can see here there's skin, subcutaneous tissue, a little bit of muscle there. And now here you can see the liver. So we're going to track that liver edge, and you can see it going all the way down to here. And then right about here you see liver headed down. You can see the liver edge here. And then something here that looks like an anechoic collection of fluid with a wall around it. That would typically be some sort of cystic structure, or it could be free fluid. The difference being a cystic structure will be bounded by a wall. So if you run through it here, you can see that, hey, there's a wall that goes around it. And right there, you're suspecting that this is probably the gallbladder. You can also see the kidney coming into view right about here. This is a little bit more posterior typically than the gallbladder, which is usually anterior on the body. So this would be a long axis sweep through. And now you're looking to see if there's any evidence of stones, which are usually going to be bright hyperechoic things that will shadow behind them, or you're looking to see if there's any evidence of the cholecystitis we talked about. I don't really see either. That looks relatively normal. The wall looks nice and thin. Now, if you're not sure, we can always look again and measure it, but visually that looks okay, and we'll show you hands-on how you're supposed to measure these things. Okay, for the next view, we're going to move on to what is an attempted short axis. Now, the reason I have this up here is because every patient is slightly different, and so each patient might have their gallbladder oriented slightly differently. On this particular patient, it was actually very hard to get a true short axis view. So you have sort of this pseudo view where you can see at about 45-degree angle, which is really not ideal. So now they do it again, and you can see here that this is a little bit more okay of a short axis view. And the goal is to sweep through from beginning to end. And as a reminder, sweeping is when we'll sort of have the probe flat, and then you'll change the way the probe is oriented without actually moving the probe towards either curved end. You're just sort of tilting the probe away and towards you. Again, this will be easier when shown hands-on. Here's an example of how you measure the gallbladder wall. You'll want to be perpendicular to the wall, and then you'll measure the thickness. And a thickness of 0.3 is considered normal. Okay, moving on. Another woman comes in with severe abdominal pain. And you take a look, and you see the structure. So we'll walk through basic anatomy again. Skin, subcutaneous tissue, some muscle there, the liver there. And now you're seeing right here, this looks like the gallbladder for sure, but then you see this bright, huge hyperechoic thing that starts up right here. So hyperechoic spot here, and then you can see that it shadows like crazy away from you. And that shadowing would argue that this is a gallbladder stone. We can talk about the subtleties of gallbladder ultrasound and about shadowing items, about things in the gallbladder that don't shadow. But generally speaking, if you see a bright hyperechoic structure in the gallbladder and you see a shadow behind it, you can be pretty confident it's a stone. Now this is a gallstone. The second question to follow is whether there's evidence of cholecystitis. And there, as we talked about, you're looking for pericholecystic fluid. And we'll talk about that momentarily. And you're also looking to see whether or not there is any gallbladder wall thickening. Let me show you this view in long axis now. So here's the view in long axis. You can see this is the gallbladder. You can see that they're sweeping through in long axis, and here you can see you have this huge hyperechoic thing, and it shadows the whole way down. That's a nice view through. Okay. So moving on. Our third patient presents with severe abdominal pain. Seems to be an epidemic. And now, you're looking through, and you're trying to decide if there's anything abnormal on this ultrasound. So we'll start by going back to your long axis view. So on the long axis view here, here's your gallbladder wall right there, as we talked about skin, subcutaneous tissue, liver here. Now that looks like the gallbladder, and then as you're sweeping through the gallbladder, if it'll actually pause where I want her to. So you can actually see right here, this hypoechoic space, it looks like pericholecystic fluid. And then if we pull it back, right here is a little bit more fluid. And you can track that and see that that looks a little abnormal. I don't see any gallstones, which is great, but it does look like there's maybe a little fluid around there. Now, a sonographic Murphy sign is very similar to a regular Murphy sign, except in this case you're actually using the power of ultrasound to better refine your physical exam. because in this case you actually visualize the gallbladder fundus, and when you push down, if the patient has a sudden increase in pain and a cessation of inhalation, that would suggest a sonographic Murphy sign. Okay, now here I'm getting another view in short axis, and you can see that they're taking their time going through it and showing you really just this one space. Now the gallbladder wall does look a little thickened, and then if you're looking around you can see again just a trace of that pericholecystic fluid down at the bottom. And now here, when they measure the gallbladder wall, remember you always want to measure at the most anterior part of the gallbladder wall from the rationale that you actually get a artifact which expands the size of the wall when you go through a fluid-filled structure. It's called posterior acoustic enhancement. So you want to make sure you're measuring just the anterior-most portion of that gallbladder wall. And that's how you'd look for a thickened gallbladder wall. If you have questions, this is my email. This session is going to be a little different because of the fact that gallbladder is generally considered a relatively easy topic. I am including some bonus content, which is essentially the FOST exam, which you'll hear about momentarily in the next video. That is optional to be covered at the instructor's discretion, depending on how much time they have for teaching. If you have any questions, please feel free to reach out, and look forward to seeing you soon.